教授同埋兒科學系嘅主任，亦都係香港兒科學會嘅會長。佢今日嘅主題就係題目就係新生兒低血壓嘅治療。請。
下一頁係。好多謝。係好多謝霍主席嘅介紹。更加多謝何鴻燊博士醫療拓展基金會嘅邀請，同埋阿禤先生嘅邀請。我本人感到非常非常嘅榮幸，再次可以嚟到澳門。因為我全部嘅幻燈，熄咗，唔好意思，熄咗。因為我全部幻燈片咧都係用英文嘅，咁啊同埋咧我嘅年齡都就嚟要去睇下戴教授㗎啦，咁啲轉數就所以會慢少少。咁如果我用翻中文講咧，我諗大家個查歇咧就一定開唔成㗎啦。咁啊所以咧就我都係用翻英文講比較快少少。啱啱個幻燈片熄咗。唔好意思，唔知點解熄咗。So, good afternoon, ladies and gentlemen. This afternoon topic is on the treatment of hypotension in preterm babies. Now, the content of this afternoon talk will be a brief introduction followed by the different treatment of hypotension in preterm babies in terms of volume, inotropes, and hormone replacement. And thereafter, I will elaborate a lot more on the latest hormone replacement therapy and at the end, a conclusion. By definition, preterm infants was defined to be hypotensive in terms of a very arbitrary definition of the infant gestational age in completed weeks. In effect, if you have a 26 weeks baby, the mean blood pressure will be 26 millimeters of mercury. Other people have used a centile chart. The problem about the centile chart is that the baby's blood pressure will gradually increase within the first few days of life. There are also other reference charts that could be used, but they are very clumsy and complicated. So at the end, we still use the first definition. Now, there are many mechanisms that the preterm babies can have low blood pressure, partly because they may have low blood volume, because they are very edematous, or the fluid goes into the lungs or to the skin, and they have a very large surface area, so they evaporate the body water very quickly. We take a lot of blood from the baby, and also there's a risk of hemorrhage, especially from the gut and from the brain. There are also another mechanism of myocardial depression because of birth asphyxia, and more importantly, there is hormonal deficiency, especially on the adrenal axis. We also use high pressure, positive pressure ventilation, in which case the heart will be compressed, and also the pulmonary circulation would also be compressed by the very high pressures. Other mechanisms involve hypothermia, infection. Everybody knows that infection will give rise to low blood pressure, cardiac problems, especially patent ductus arteriosus, and also a very important factor, vascular tone deficiency. And also the drug we use, like morphine, fentanyl, they all would drop your blood pressure. So essentially, there are three major mechanisms dropping the blood pressure: decreases the venous return, decreases stroke volume, inadequate tissue perfusion give rise to more hypoxia and acidemia, which give rise to a positive feedback loop. And the adverse outcome of hypotension, a lot of people have realized it and has been shown to have hypoechogenic parenchymal lesion. What it means is ischemia to particular part of the brain, hemorrhage, and also dilatation of the ventricles. They've seen this complication in 53% of hypotensive newborns as compared to only 8% in normotensive newborns. Those are all preterm babies. With regard to the adverse outcome, there are a retrospective study being conducted recently, and those with hypotension are more likely to have delayed motor development, hearing loss, and also death. So the treatment for low blood pressure is either to give them back the volume, either with blood, crystalloid, colloid, use of inotrope or vasopressors, mainly dopamine, dobutamine, adrenaline, or in our specialty, we are now advocating also the use of hormonal replacement therapy with corticosteroids either in the form of hydrocortisone or dexamethasone. So first is to look at the question, what should we give first, inotrope first or volume expansion? Now, it is very difficult to differentiate between the two mechanisms, and more often than not, they coexist together. So in the first study, which is conducted in the early 90s, they tried to find out whether the use of plasma protein fraction as compared to dopamine to ask which is better. The problem about this randomized study is that all the babies were initially given 20 mils per kilogram of plasma protein fraction, in which case they are already given volume. But what they found is that a significant proportion of patients were resuscitated with PPF, and the study only demonstrated infants who subsequently develop hypotension are likely to have myocardial dysfunction and more likely to respond to dopamine. So it's not a very good study. Treatment of blood transfusion, some doctors like to treat the baby with blood transfusion. Unless the hematocrit is low or the hemoglobin is low, I don't think there is any point treating with blood on every occasion. And it will also increase your hepatic iron deposition. In a preterm baby, they will be transfused many, many times. Another study look at whether it's the volume, which is the important factor, or whether it's the protein load in the volume expander, which is important. And that's the reason why they compare 20% albumin with FFP and with 4.5% albumin. And the conclusion is that the volume infused rather than the albumin load is more important in keeping up the blood pressure. So volume rather than the protein. Also, in large studies comparing colloid-like albumin with crystalloid-like normal saline to see which is better. This is an adult study, a meta-analysis study published in the BMJ, and what they found is that resuscitation with colloid, that means albumin, are associated with increased risk of mortality. 4 extra deaths per 1,000 patients, per 100 patients treated. So 4% extra death. Another study looking again with albumin and normal saline, more or less similar conclusions. In a subgroup analysis, they revealed that crystalloid resuscitation is associated with lower mortality. When we group every single subgroups of patients together, children as well as adults, again, it is the risk of death in the albumin-treated group was significantly higher than the crystalloid group. So albumin is worse than normal saline. And the overall percentage is that you can save 6 more patients using crystalloid, normal saline. So normal saline is cheaper and better. So the proposed mechanism is that it is because of the anticoagulant properties, because it inhibits platelet aggregations, and also the albumin may leak into the extravascular space and also worsening the edema, giving rise to more hypotension. So in the late 90s, Professor Falk and our team have performed a study investigating the use of albumin and normal saline in preterm infants. What we found is that those who receive albumin require significantly more volume expander to maintain a normal blood pressure. And also the weight gain in those patients are significantly higher, meaning that a lot of the albumin are being leaked to the extravascular space. So our conclusion at that time is that normal saline was as effective, at least as effective as 5% albumin in treating hypotension, but it is cheaper and have less fluid retention. So basically, again, normal saline is probably better. Another more recent study comparing colloid, crystalloid, and starch preparation, unfortunately, there was no evidence that the starch preparation was superior. Next question to ask is that, okay, we know that normal saline is probably best. Next question is which inotropes or which vasopressors? Is it dopamine or is it dobutamine? In the late 80s, there's a case series study suggesting that probably dopamine is better than dobutamine, and you have to prescribe with a rate of 10 microgram per kilogram per minute before it is effective. The dose lesser than that is not as effective. So another randomized control study comparing dopamine and dobutamine, it suggested that dopamine had a significantly higher, can achieve a significantly higher median systolic blood pressure, 39 versus 34. Similar study, all 10 infants were successfully achieving the target range of blood pressure, whereas 6 of 10 infants failed in the dobutamine group. So again, dopamine is better in raising your blood pressure. Another study, more or less the same conclusion. The increase in mean arterial blood pressure was significantly higher in the dopamine group than in the dobutamine group. So from all the randomized control study, it points to a very major point, and it's that dopamine has been shown to be more effective than dobutamine in increasing the blood pressure in preterm infants. Another latest study, which is conducted in 2006, comparing low to moderate dose of dopamine versus adrenaline. And the conclusion, what they found, is that they are more or less as effective. Both treatments are effective, but those with adrenaline are associated with more transient side effects. The transient side effects are glycosuria and high blood sugar, which need the use of insulin. So much so for the conventional treatment. Very special to the preterm baby is the hypothalamic pituitary adrenal axis, because this axis undergo a very dynamic change during fetal development and also after birth. They exhibit a remarkable transformation in size, morphology, and function in the first few weeks of life. So normal development of this hormonal axis is essential for three functions. First is a regulation of intrauterine homeostasis for the fetus, influence the timing of delivery, and also maturation of vital organ system, including the lungs and the brain. So this is a very complicated diagram, but what it means is that it demonstrates the three factors that I mentioned. It's responsible for maturation of the organs, and through a lot of negative and positive feedback mechanism, it controls the homeostasis or the blood pressure in the fetus, and also in conjunction with the placenta, it will control childbirth, the timing of childbirth. So far there is no major evidence to suggest that clinical adrenocortical insufficiency in term babies exists, despite the dramatic remodeling. Having said that, there are some literature that's saying that they are still not as good in controlling the blood pressure in the first few days of life, even in term babies who is ill. But ill and extremely preterm infants, especially those less than 1 kilogram, have decreased ability to produce adequate amount of corticosteroids. There are many studies which support this evidence. When we look at the steroid precursors, they are markedly raised, and there is a low end product of cortisol, indicating that the adrenal enzyme system is not matured. Another study, again, 7 times, 18 times, 8 times increase in intermediate metabolites, whereas the cortisol level, which is the target hormone, is very low, suggesting that there is a 11-beta hydroxylase deficiency. Similar study by the Americans, again reviewing exactly the same results. So in animal study, we also seen that there is significant increase in mean arterial blood pressure during cortisol infusion in preterm sheep fetuses. There's also an association with a significant improvement in cardiovascular function a few hours after hydrocortisone replacement in those primates. So there are evidence in animals. How about in human? Now, we have found babies with refractory hypotension in a proportion of preterm babies. They are very preterm. They're less than 28 weeks usually, or even more so, less than 26 weeks, extremely low birth weight, less than 1 kilo. They have severe hypotension occur within the first few days of life. They do not respond to volume expansion and do not respond to vasopressor support. The blood pressure will remain extremely low, but readily responds to systemic corticosteroids, and we were suspected to have adrenal cortisol insufficiency. In fact, we have demonstrated in a series of studies, which I have not mentioned here, that they have intact pituitary function, but adrenal glands enzymes were deficient or inadequate. We have done another study correlating the cortisol and the inotropes and the volume expander, and what we found at day 7 is that the lower the cortisol level, the more you need your inotropes and also your volume expander and your duration of your inotrope support. Multivariate analysis further suggested that cortisol remains significantly associated with the blood pressure and the duration of vessel support. We have also studied with an HCRH test in preterm babies. Those are normal babies which do not require inotropes, and those are the ones with low blood pressure, and you can see that the cortisol level were much lower in the hypotensive group. Now, with regard to treatment, this is a study published by the Germans, and with refractory hypotension, they use adrenaline for treatment, and those who require adrenaline were given corticosteroids in form of high-dose dexamethasone. Those who are given dexamethasone, the great majority, or over half of them, will be weaned off the inotropes within 12 hours. That's a very quick time, whereas 1 out of 9 babies receiving saline or the placebo would be weaned off. However, they use a rescue treatment after they gave the dexamethasone. 5 out of 8 infants were weaned off adrenaline in 1 to 7 hours. Another prophylactic study performed by the Americans suggested that those at birth, no matter what, they were given hydrocortisone, and with that, they found that a lot of babies do not require inotropes at 48 hours compared with the one that was given the placebo. So they suggested that prophylactic hydrocortisone treatment reduced the use of inotropes. The only problem is that they have to terminate this study earlier because there is gastric perforation in the hydrocortisone group. We at the Chinese University of Hong Kong also performed a study with a stress dose of hydrocortisone. That means double the dose of the physiologic production of hydrocortisone in the preterm babies. And only in babies with refractory hypotension, we first gave it saline, and that doesn't work. And we gave them dopamine, 10 mites per kilo per minute, and still doesn't work. We randomized into hydrocortisone group and the placebo group. And what we found is that the vasopressor were weaned off after 72 hours in almost 80% of babies given hydrocortisone, whereas only about 33% weaned off in the placebo group. Also, the duration of inotropic support is much shorter, and also the use of a second vasopressor is much less, and also the amount is much less, etc. So we suggested that in a selective group of babies with refractory hypotension, there is a role for the use of hydrocortisone or corticosteroids. However, at the same time, with the fear of GI perforations, we also use a proton pump inhibitors, try to prevent these important complications. Now, this is the blood pressure. During our randomization, the blood pressure are more or less the same between the two groups. The blue line represents the hydrocortisone group, whereas the red line represents the placebo group. You can see the blood pressure is significantly higher, and then they merge back at about 7 days of life. Another study that we have performed, in fact, this study was performed by Professor Falk, using inhaled corticosteroids for treatment of RDS. And with his permission of looking at the data retrospectively, we also look at the blood pressure. We did give a pretty high dose of inhaled flucortisone. And what we found is that there is a significantly decreased use of volume expander in the inhaled corticosteroid group, and also a trend suggesting that it's useful or lesser use of a dopamine also in the inhaled corticosteroid group. So even if you give inhaled corticosteroids, some of the corticosteroid will be absorbed, and that lead to significantly less volume expander being needed by the baby. The mechanism of steroids has been proposed to be the ability to increase the density of beta-adrenergic receptors. Also, it can reverse the desensitization effect of prolonged corticocholamine exposure on the receptors, and also it could increase the angiotensin II receptor gene expression. Those are the mechanisms of the glucocorticoid, rather than increasing the sodium retention in the body. So, in conclusions, ladies and gentlemen, I have spoken about the treatment of use of different mode of therapy for treating hypotension in preterm newborns. With regard to volume, I think normal saline would be good enough. And with inotropes, the first choice is still dopamine. And if everything fails, then it is worth a short course of corticosteroids in those patients with really, really low blood pressure and did not respond to either method of treatment. Thank you.
好多謝吳教授一個非常之專題嘅講學，我相信亦都係highlight到中文大學 同埋霍院長啊，佢哋多年嘅對初生嬰兒嘅研究同抱負。咁我諗呢度睇下在座有冇任何嘅問題想問下吳教授。或者吳教授，你可唔可以先解釋？因為我諗大部分喺度嘅人都未必係喺深切治療，即係初生嬰兒深切治療部工作過。咁點樣係喺呢啲咁細嘅 BB 度，我哋可以準確去量度住佢哋嘅血壓，等可以跟進你嘅治療咧？
係呢個係好好嘅問題。我哋深切治療部咧，其實呢啲咁早產嘅 BB 咧，我哋每人咧都會有一個導管擺咗落去個動脈嗰度嘅。咁其實每秒鐘我哋都係睇住嗰個血壓嘅情況。咁而我哋用嘅血壓咧，就係個 mean arterial blood pressure。我哋唔係睇最高嗰個，亦都唔係睇最低嗰個，係睇中間嗰個。咁通常嗰個都好準，因為嗰個都係跟住嗰個高systolic 同埋 diastolic 嗰個走嘅。咁其實咧呢個就最準確嘅方法嚟嘅。但係有啲副主席就會問如果有啲擺唔到呢啲咁嘅導管嗰啲又點算咧？咁樣其實擺唔到導管嗰啲咧，就其實而家咧我哋用嗰啲自動嘅血壓計咧，嗰啲 Dynamap 嗰啲咧，都有啲係專係為初生嬰兒做嘅。雖然就冇咁準，佢哋咧就會嘗試就係度得高咗少少嘅，大約10% 咁左右。但係而家啲科技越嚟越好咧，其實咧就應該係都好準確㗎啦。即係嗰啲量度，同埋最重要咧，都係大家都知道度血壓都係嗰個 cuff 嘅問題咧，個 cuff size 一定要好準至得，因為要好適合至得。如果太細或者係太大咧，都會令到個血壓高或者係會低嘅。
係。好多謝伍教授嘅詳細解釋。咁咧就我都係喺兒科度做嘢嘅，我就想請教一下伍教授咧，關於因為我哋自己臨床都會碰到呢啲咁嘅 situation 啦。咁你頭先都提過話用咗嗰個inotrop 或者係 saline 去處理佢個 low blood pressure 之後咧，冇效嘅時候，我哋可以嘗試用 corticosteroid 去治療。咁一般嚟講，我哋即係譬如我哋嘗試用呢啲治療，喺咩嘅時機裏邊去用 corticosteroid 係比較合適啲咧？同埋咧，我哋需唔需要去 check 一 check 佢嗰個adrenaline 唔係adrenal gland 嗰個係啦，check 唔 check 佢嗰啲咁嘅 level 係咪 suitable 去用呢個 corticosteroid 咁樣咧？係
呢兩個問題都問得非常之好，因為呢兩個問題都困擾我哋好耐，即係去到邊個地步我哋至適合用呢個 corticosteroid 啦。因為喺早產 BB 用 corticosteroid 咧，有個最唔好處咧，就係令到兩樣嘅唔好處。第一個唔好處咧，就會令到，因為佢對個 DNA 即係嗰啲細胞嘅 DNA 係有影響嘅，所以佢有可能如果你俾得個劑量大嘅話咧，同埋好早去俾 corticosteroid 嘅話咧，佢會影響個腦部嘅發展嘅。呢個第一。因為第二咧就係佢會corticosteroid 咧就亦都會係令到會腸穿嘅，就係通常穿嘅地方咧就係喺個胃部或者係 ilium 嗰度穿嘅，咁呢啲係最常見嘅。咁同埋咧第一個條件咧就係一定唔可以 corticosteroid 同埋 indomethacin 一齊用，因為我哋用 indomethacin 消炎痛咧就愛嚟閂個心導管嘅。如果兩個一齊用嘅話咧，就會 increase 個 risk of perforation 咧就10倍嘅高。咁所以一定第一呢個係第一先決條件啦。你用咗一個你就唔可以用第二個噶啦。呢個第一。好啦，咁講翻我哋個 unit 個 policy 係點樣咧？其實我哋個 policy 一路都變緊嘅，因為初時咧我哋又用好多水嘅，咁發覺呢啲水咧就浸住自己個肺咧，咁就好難會掹到條喉，即係 BB 嗰條喉好難掹嘅。咁所以咧我哋而家咧就減少用水，減少得好多，因為其實好少嘅早產 BB 真係 hypovolemic 嘅。咁就所以我哋而家係用2劑水嘅啫，10 ml per kilo 一劑，睇佢得唔得？如果再唔得，用多一劑。如果個 blood pressure 都仲唔升嘅話咧，咁我哋就開始去 start 嗰啲 dopamine 㗎啦。咁dopamine 其實我哋用到個劑量都好高嘅，用到20 米 per kilo per minute。 咁如果唔得嘅話咧，就再加多隻 dobutamine 落去啦。由一路用到大約10至20米都仲唔得嘅話咧，咁我哋就要加 adrenaline 嘅啦，即係第三層次就要加 adrenaline。如果加 adrenaline 嘅話咧，我哋就會開始會思想下應唔應該用呢個 hydrocortisone 啦。就通常係 dopamine fail。dobutamine fail， 我哋就諗hydrocortisone，我哋都唔係立亂用。一年其實以前我哋就俾得鬆手啲，因為唔知道有咁多嘅 side effect。但係而家咧，我哋就俾得好手緊，因為真係嗰啲需要嗰啲，我哋自用咯嚇。咁呢個就我希望解答到你第一個問題。第二個問題咧，就需唔需要用cortisol 嚟即係度咗 cortisol 先。嗱，我哋個 lab 咧就比較夠運啲，因為我哋 send 啲 cortisol 落去咧，就6至8個鐘頭咧就有個 result 翻嚟㗎啦。咁如果我哋去到用個第二個 inotrope， 我哋都見到唔係好對路啦。咁我哋都會 send 落去嘅。咁咧，但係個最大問題係點樣去即係解釋嗰個翻嚟個 result？ 咁呢個係高啊、低啊，定係唔係咩咧？咁呢個其實好複雜嘅問題嚟嘅。咁啊，所以咧，唯有一樣嘢我可以話俾你聽，如果個 cortisol 翻到嚟係高嘅，即係高過200個 nanogram nanomole per liter 嘅話咧，咁我哋通常就唔用啦，因為而家我哋文獻知道咧，如果你高嘅 cortisol， 你再俾啲 cortisol 佢咧，好可能咧會出血嘅，即係腦出血嘅。咁所以一高咧，我哋一定就唔會用啦。咁啊低到邊個程度你會用咧？咁啊呢個有好大問題啦。咁其實我哋啱啱咧就應該係呢個禮拜內咧會 submit 另外一份文獻，就係講關於點樣去 interpret 呢個 cortisol level。咁咧就其實咧我哋都係因為好多個原因啊，而令到個 cortisol 係高同埋低嘅。因為我哋見過BB 好正嘅 BB， 好 healthy 嗰啲好低 cortisol 嘅，但係佢血壓冇嘢嘅。但係亦都見過有啲好嚴重嘅 BB， 嗰啲 cortisol 好低嘅，咁嗰啲啊梗係可能會有 benefit 啦，嗰啲咁樣。咁啊點樣去 interpret 咧？咁啊其實我就同一個統計學嘅，即係中大一個統計學嘅教授咧一齊就會發表呢一篇文章，就應該去點樣解。咁就其實我哋係用一啲 mathematical 嘅 model 去睇一睇你即係邊一個情形加埋晒，咁我哋 adjust 咗一個 percentile 出嚟嘅。咁我哋會第日會有個 website 搞出嚟。而家個 website 已經做咗啦，不過而家仲係有啲嗰啲數計得唔準啊。咁因為嗰啲程式嗰度要修改少少，就係個 website 已經做好咗㗎啦。第日我哋發表嗰篇文章嗰陣時咧，會加埋個 website 喺嗰度，咁你可以一 click 上去。打咗病人嘅資料，咁佢就會俾一個 adjusted 嘅 percentile 俾你，即係呢個情況嘅 percentile 係幾多？咁咧其實個 percentile 都唔可以話俾你聽，你應該用唔用嘅。咁你要睇下啊，如果個 BB 個血壓又咁低，個 adjusted percentile 又咁低嘅話咧，或者都應該用喎咁樣嚇。咁暫時可以解答到你咁多。
請問仲有冇其他問題咧 ？OK， 如果冇嘅，我哋再次用掌聲多謝阿吳教授。
好，
我諗喺度我諗大家都聽咗4個好精彩嘅講座，咁我諗係大家都有啲疲勞啦。咁我諗而家有個休息俾大家20分鐘，咁跟住咧落嚟咧，我仲有4個一兩咁精彩嘅講學嘅，多謝大家。
好多謝晒霍雲信先生醫生。現在茶點時間，咁就第3部分嘅研討會咧，將會係4點半準時開始嘅。咁至於出席證書咧，亦都會喺整個研討會完結之後咧，先至可以喺登記處索取嘅。咁請各位到外面慢慢享用茶點。